All right, perfect. So, welcome for sinusitis for QE1. Two types of sinusitis we have. One is acute and second one is chronic. Acute, we are not going to discuss today. We are going to chat about chronic sinusitis, right? Acute, you guys know a lot of things. Infectious Disease Society of America has guidelines on it as well. So, not as much about acute, but more about chronic. Good. All right, moving on. Why does chronic rhinosinusitis or CRS matter? Why it matters for QE1? So it is very commonly seen as chronic sinusitis, often misunderstood. We think of something else. It is more of inflammation than infection. Acute sinusitis, everybody, is most commonly an infection, which is caused by what? Acute sinusitis, most commonly an infection, which is caused by what, everybody? Most commonly caused by? Very good. Most commonly, it is caused by viruses. Good. So acute sinusitis, most commonly, it is a viral infection, right? On the other hand, chronic sinusitis is an inflammation, then an infection. There are a few reasons for it. In pathophysiology, we are not going to dive deep into it today. Major impact on quality of life. It can cause fatigue, sleep disturbances, depression, and a lot of other things. Overuse of antibiotics can be a big distractor in the exam. Antibiotics usually do not help as much in chronic sinusitis as in acute ones. So make sure you remember this point on overuse of antibiotics. And main thing for you to remember is a definition symptom of more than 12 weeks. Definition symptom of more than 12 weeks. Good. Okay. Core presentation and diagnostic criteria. So symptoms, you need two or more. So nasal obstruction, congestion, discharge, reduced sense of smell, facial pressure, fullness, all of those things, right? So core symptoms, okay, and they are your obstruction, discharge, reduced sense of smell, facial pressure, two or more, enough. And you need an objective finding. So everyone remember this. Subjective findings are things like fever and pain. All of those things are subjective findings. Objective findings are something that you can actually document black and white, right? Like fever, what do you mean? Well, the thermometer measured that your temperature is 102 Fahrenheit or 39 degrees Celsius, right? That's an objective finding. Good. So for chronic rhinosinusitis, you do need objective findings for full diagnosis. So nasal polyps, edema, or mucopurulence on endoscopy. So sometimes polyps are easily visible. You can do it even with regular examination if you're able to notice it, see it, all of that. Mucosal thickening or opacification of the sinuses on CT scan, right? So when you do CT scan, if you see the mucosal thickening or opacification, then that's your another objective finding. Usually it is bilateral. If it's unilateral, it is a red flag. Good. All right. So let's say somebody comes to you with symptoms of chronic rhinosinusitis. What are some of the differential diagnoses that you know of? Tell me what could be some of the differential diagnosis in this case. COVID-19, what? COVID-19 myocarditis? No, be specific, right? What are some of the differential diagnoses, everybody, of chronic rhinosinusitis? Only one person? Come on. We have, how many people do we have? 27 people. Okay, good. Allergic rhinitis. Very good. What else? Dr. Sila said it. Marianne said it. What else? Allergic rhinitis. Anything else? Cellulitis of what? So what are some of the differential diagnoses? Let's resume and let's take a look at some of the differential diagnoses. So you can have allergic rhinitis, very good. Dr. Samantha's iPad, allergic rhinitis. What else? Deviated nasal septum is another one. Septal deviation is another one. Vasomotor rhinitis is the third one, right? Vasomotor rhinitis or neoplasms and stuff, right? Neoplasms and stuff. Inflammatory disease? No, no. You need to be specific. You can't just say inflammatory disease. All right, good. So some of the differential diagnosis, I'm sure there are way more, but this is some you have to remember. Septal deviation is very common. Allergic rhinitis is very common. Make sure you remember it. Do not forget that. All right. Management. So what is some of the management in this case scenario? So high yield QE1 based management stuff, very important for most patients. First line is usually intranasal corticosteroids. Okay, so long-term corticosteroids or intranasal corticosteroids. First line, good. Saline irrigation is another one. High volume saline irrigation. People use neti pot and stuff like that. That can also be considered, right? Selective use, so short oral steroid burst. If you see nasal polyps or something, you can give 5 days, 10 days, whatever it is, of prednisone, oral steroids, you can consider as well. And if you do see patients who have fever and greenish yellow mucus coming out and so forth, you can consider antibiotics as well. Now, what antibiotics are good for any sinus related infection? Do you guys know what would be good antibiotics for sinus related infection? Good. Amoxicillin usually works, right? Amoxicillin usually works, so that can be first line antibiotic for bacterial flares. If it is still refractory, right? If it is still refractory, then you can consider endoscopic sinus surgery, or you can consider biologics like Dupixent and stuff like that, right? Biologics like Dupixent and stuff like that. Or Xolair, omalizumab, mepolizumab, dupilumab, right? Biologics you can consider as well. So previously, I used to tell people that don't worry about biologics, don't worry about biologics. But now I would say biologics are quite commonly prescribed, and probably in next 5 years or so, they might become mainstream where primary care starts prescribing biologics as well. So I would say the most common biologics, you should at least remember some of them, like in inflammatory bowel disease and those conditions, at least some names, then it'll become easier for you because there is a chance that exam can ask this. Good. All right. Short topic today. Let's do some take-home messages. Do not diagnose chronic rhinosinusitis with objective findings. So what were the objective findings, everyone? What were the objective findings? We had some objective findings. What were they? Subjective, you knew nasal obstruction and things like that. What are the objective findings? Good. You can see nasal polyp or something, right? Discharge, no, no, no discharge. Edema, no. So let's talk about objective. You're talking about subjective findings, right? Subjective findings were nasal obstruction, discharge, reduced sense of smell. Those are subjective. Objective, oh yes. So nasal polyps, edema, or mucopurulence on endoscopy. Not just looking at somebody's nose, right? Not just looking at somebody's nose. But when you see this on endoscopy, polyp can sometimes be seen by regular physical examination of the nose, right? Sometimes it can be seen. But edema, mucopurulence, all of that on endoscopy is one criteria. And second one is a CT scan. CT scans showing mucosal thickening or opacification, right? Opacification. That's the main thing over there. Plain sinus x-rays we used to do 10, 20 years ago, but low value now, right? So sinus x-rays are essentially obsolete. We don't do sinus x-rays as much anymore. If someone has unilateral symptoms, fever, severe pain, unilateral symptoms, think of something else, right? Like an infection or something else. Okay. Please remember, it is not chronic infection, it is inflammation. And that's about it. Good. All right. Let's pause over here.